we will be discussing the second lecture on the very frequent cardiac consultations. Last time we discussed pregnancy and heart disease, and this is the non-cardiac surgery and heart disease. Every one of us has consultation, of course, of this kind. Now, what is supposed to be done by the consultant cardiologist, or the one who is responsible for giving a consultation about the cardiac patient? He's supposed, number one, to give a diagnosis as much as he can. And number two is to try to find the risk factors for cardiac surgery. And try to diminish the risk factors as much as possible. In the meantime, he should be able to communicate effectively with the anesthesiologist and the surgeon, trying to find out how much, what kind of surgery and the details of this surgery as much as possible, so as to find out a mental picture of the risk of surgery. And then he should be ready if he is needed during the operation, and of course participate in the post-operative care of this kind of patients. He is not supposed to clear the patient for surgery, because clearance means transferring the medico-legal responsibility from the surgeon and the anesthesiologist to the cardiologist. That's totally unacceptable. Now, having said that, let us go to some definitions. An urgent surgery means that is a surgery that has to be done, and the patient should be in the operating room within 6 to 24 hours. Time-sensitive surgery is to be done within 1 to 6 weeks. An elective procedure can be delayed up to 1 year. A low-risk procedure means the occurrence of adverse cardiac events or MACE or death and myocardial infarction less than 1%, and if it is more than 1% or equal to 1%, then it's elevated risk. This is the American recommendations. The European recommendation deviates from this slightly, and I will tell you about it in a second. Now, why non-cardiac surgery is dangerous? Because of these factors: catecholamine surges, prothrombin milieu and hypercoagulable state because of the incisions, blood loss, volume shift in different spaces, including the third space, peritoneal cavity, pleural cavity, and so forth, coronary plaque destabilization, and fixed coronary disease. Now, I wanted to call your attention that the exercise test, which is frequently asked for this kind of patients, only predicts 1 out of these 6 factors, the last one. It cannot detect the first 5 things. So that's why we are doing much less exercise tests for these patients nowadays than a decade ago. Now, as you see here, catecholamine level rises within the first 24 hours, and norepinephrine continues to rise in vascular surgery up to 2 weeks. Now, this is the master algorithm taken from the American and very similar to the European guidelines. If you have an emergency surgery, then the patient can be evaluated very quickly, correct whatever can be corrected, like hypoxia, electrolyte, and acid-base imbalance, and then he can go to the operating theater. If it's not emergency surgery, then is there any active cardiac condition? And I will detail about that. If there is an active cardiac condition, then it should be evaluated and treated according to the guidelines. If there is no active cardiac condition, then we make a mental picture of the combined risk of surgery as well as the patient characteristic. And if this combined mental picture that I'm going to explain reveals a low risk less than 1%, then you don't need any further testing and the patient can proceed to surgery. If the risk is not low, it's elevated, then we ask about the functional capacity of the patient. If the functional capacity is acceptable, then he can go to surgery without further investigation. Only when the patient has a low or unknown functional capacity, then a stress test, probably a pharmacological stress test, is to be considered under these circumstances. So as you see in this algorithm, we have 4 unknown factors that need explanation. And the first item is what are the active cardiac conditions that need to be explored so as not to proceed with surgery, to stop surgery, and you attempt to correct these 4 factors. Of course, acute coronary syndrome, decompensated congestive heart failure or worsening of new onset heart failure, significant arrhythmia like ventricular, supraventricular arrhythmia, conduction defects, malfunctioning pacemaker, and severe valvular disease. So as you see, all of these are clinical examination, good history and the clinical examination is sufficient to explore these things. And this is the main responsibility of the cardiologist to find out any of these 4 things. They don't need any investigations except history, physical examination, and looking at the electrocardiogram. Now going to step 3, which is the cardiac risk. This has been variously called over time by different names: Goldman Index, Detiski Index, Eagle Index, and now it's called the Revised Cardiac Risk Index. It's almost the same over the last 30 years. So the patient factors which increase the risk are, is he having coronary artery disease, heart failure, cerebrovascular accident, insulin requiring diabetes, renal insufficiency with creatinine above 2 milligrams per deciliter, or we are going to proceed with a high risk surgery. This means a suprainguinal vascular, intrathoracic or intraperitoneal surgery. As you see, most of the risk is related to the patient, not the kind of cardiac surgery. You have here 6 factors, only 1 out of 6 is related to surgery, and the other 5 are related to the patient. I want to call your attention to the third item, cerebrovascular. If you have a recent stroke within 3 to 6 months, that's a big deal. That's a big risk factor because the cerebrovascular accident results in a generalized inflammatory state and increases the mortality because of cardiac infarction, because of myocardial infarction, rather than because of the cerebrovascular accident itself. Now, if we go to step 5, what are the specific surgical procedures that carry a high risk? As you see, as we proceed upwards here, we are talking about vascular surgery, essentially, aortic and non-carotid. The carotid is medium risk operation, non-carotid peripheral vascular, major thoracic, major abdominal, and then medium risk carotid and head and neck and orthopedic, and lower risk is eye and skin like plastic surgery and cataract. Now, it's very important to notice several things here. The non-carotid peripheral vascular, like femoropopliteal, although it's a lower limb or lower extremity operation, it carries the same high risk like aortic operation. Not because it is as stressful as the aortic operation, but because this kind of patients, they have diffuse atherosclerosis, including coronary atherosclerosis and cerebral atherosclerosis, which put them at a risk as high as aortic surgery. The second thing is the so-called laparoscopic surgery. Unfortunately, most of the guidelines either doesn't mention anything about laparoscopic surgery or addresses it inadequately. There is an impression by the patients and some physicians that laparoscopic surgery is a minor surgery. Laparoscopic surgery generally is a major surgery. And it's particularly important to notice that the insufflation of the abdomen by gas, occasionally carbon dioxide, results in diminution of the venous return and the increase in the afterload and the decrease in the cardiac output by 30%. Peripheral vascular resistance increases by about 15%. Many of these patients, if they are having a marginal cardiac reserve, they go into heart failure. It's very important that the patient knows about that and knows that it's a high-risk operation, and particularly the high risk is whenever you are dealing with intra-abdominal procedures or intrathoracic procedures. So it's corresponding to exactly with a slightly lower risk than open surgery corresponding to this paragraph exactly, with the highest being the vascular surgery and the lowest being the non-endoscopic eye and skin surgery. So that's an important point to be noticed because it's usually overlooked by various guidelines. Now, this is the European classification of the risk of non-cardiac surgery: low less than 1%, intermediate 1 to 5%, and high above 5%. Then the last of the four things that we were talking about in the master algorithm is the function class. It's very important to ask the patient a very simple question. Is he able to walk uninterrupted without stopping at normal pace about 200 meters, or climb 2 flights of stairs without stopping? If he can do that, this is considered a good functional status. If he can't do that, that's a poor functional status. So if you compare people who are having a poor functional status with those of good functional status, as I explained just now, the complications including myocardial infarction, myocardial ischemia, cardiac and neurologic endpoints is just doubled. So just being able to walk for 4 blocks, or what's equivalent to about 150 or to 200 meters, or climb 2 floors of stairs without being interrupted or at a normal pace, just doubles the risk of non-cardiac surgery. So it's very simple. You just look to 3 things: clinical markers, poor functional status, and the risk of surgery. The clinical markers are what we talked about, the famous 6: coronary artery disease, heart failure, diabetes mellitus requiring insulin, renal insufficiency, and cerebrovascular accident. Any of these increases the risk by 2 to 3-fold. Poor functional status, as defined just now, increases the relative risk by about 2. And high surgical risk increases the risk by about 3. For any type of surgery, if you count the risk factors 1, 2, 3, 4, then there is a linear relationship between the risk and the occurrence of these different numbers of factors. So if you look to this diagram, there is almost a linear relationship between the number of factors and any kind of surgery, with the highest risk surgery being the arterial suprainguinal surgery, and next to it the arterial infrainguinal surgery, and the least risky surgery is a plastic surgery and a non-bowel surgery. So this is what I mean by making a mental image for the combined risk of the patient and the surgeon. So as you see here, this is the kind of surgery, and then you climb in the risk ladder here by the various factors which are belonging to the patient. Now, if you want a more sophisticated prediction index, then you can go online for the National Surgical Quality Improvement Program. You have more than 30 factors. You can plug in the different factors, and you can come up with an exact figure of the risk. The exact figure doesn't differ too much from the simplified algorithm that I just showed you, and it almost you almost get the same result. So you really need to do that. Now, when you need further non-invasive tests, number 1, if the test result is going to change the care of the patient. If you are thinking that the patient is having poor functional class, and you are thinking about changing the type of operation, or canceling the operation completely, or doing something in the form of changing medical treatment, or doing intervention for the patient, that's what is meant by changing the kind of care to the patient. Has a patient been tested recently? So there is no need to repeat the test if the test result is strongly negative. Is there any concern about coronary artery disease or left ventricular dysfunction that has not been revealed by the preceding processes? And can the patient exercise? So The patient who is an ideal candidate for further stress testing is a patient undergoing high-risk surgery, having more than 2 clinical risk markers, and is having unknown or poor functional capacity. How can we identify the patient who is going to get post-operative myocardial infarction? This is a very risky event with high mortality, triple or quadruple the mortality of the de novo myocardial infarction. The answer to this question is partially yes. Sometimes you can, but often you cannot. So if you have a patient with a left main disease, 3-vessel disease, 2-vessel disease with proximal LAD, these patients are very prone to get myocardial infarction. But in reality, more than 50% of the patients cannot be identified as having a myocardial infarction. The reason is simple. These patients, they have a non-stenotic plaque, but the stress of surgery and the inflammatory state and procoagulable state resulting from surgery can disrupt the plaque and produce myocardial infarction. So you can identify almost half of the patients, but there is a possibility that you can miss half of the patients. So these are 42 patients have been studied. All of them, they were having a hysterectomy operation and underwent coronary angiography for the sake of this study. And as you see, if you have 3-vessel disease, left main, 3-vessel disease, 2-vessel with proximal LAD, then you are on the verge of getting myocardial infarction. And despite that, if you don't have them, you still have the possibility of getting myocardial infarction because of a disturbed plaque that was not really obstructed. No benefit. For low-risk surgery, there is no benefit of doing a 12-lead electrocardiogram. There is no benefit of doing assessment of left ventricular function by echo in low-risk patients. There is no benefit in exercising patients who are undergoing low-risk operations. There is no benefit in implementing non-invasive pharmacological testing in low-risk surgery. And of course, there is no benefit of doing preoperative coronary arteriography as a routine. So as you see, I cannot emphasize the fact that most of the patients that we send to surgery, we depend on simple things: good history, good physical examination, and just looking at the electrocardiogram. Now, let us go to valve disease. Symptomatic valve disease, preferably to be dealt with before non-cardiac surgery. If not, then you have to evaluate that risk, particularly the risk of stenotic valves. Usually, regurgitant valves, they tolerate non-cardiac surgery very well. So, symptomatic aortic stenosis, there is preoperative mortality of about 10%. But if the patient with tight aortic stenosis is asymptomatic, usually they go through the operation very well. So as I will show you in the next slide, the risk drops markedly from 10% to about 3%. So asymptomatic aortic stenosis, there is an acceptable risk for non-cardiac surgery. Just avoid low preload so as to avoid decreasing the cardiac output markedly. Mitral stenosis, avoid having tachycardia, because tachycardia will increase the gradient by shortening the diastolic filling of the left ventricle. Now, if you look into this diagram on the right, comparison between asymptomatic and symptomatic severe aortic stenosis, and as you see, the mortality decreases from 10% to 9.5% to 3.3%. Same applies to MACE, marked decrease in the mortality. So if you get a severe asymptomatic aortic stenosis, then you can proceed to surgery without major problems. You don't have to interrupt the patient, do something for the aortic valve, and postpone the non-cardiac surgery. As I said, valvular regurgitation, they are generally tolerated very well, but avoid cross-clamping in patients with severe aortic regurg. Maybe you resort in these conditions to endovascular therapy rather than going to open heart surgery and doing aortic dissections or aortic aneurysm, because the presence of aortic regurgitation with cross-clamping will increase the regurgitation and let the patient go into acute pulmonary edema. What about mitral regurgitation? Usually they tolerate surgery very well. If you look into the 30-day mortality, there is no statistically significant difference between severe mitral regurgitation and no mitral regurgitation. But myocardial infarction, post-operative heart failure, and post-operative stroke, they might increase, or there is a tendency for them to increase in severe mitral regurgitation. So this recommendation we just explained. What about patients with heart failure? The most important thing in heart failure patients undergoing non-cardiac surgery is to find out the physiology. If you have heart failure with preserved ejection fraction, then probably you should avoid general anesthesia. It's very important to realize that we should not direct the anesthesiologist to what kind of anesthesia or the technique of anesthesia that he should do. This is unacceptable and it doesn't work. But you can tell him that the ejection fraction of this patient is very low, and probably if he takes an inhalation anesthesia, then it might further lower the ejection fraction, which is quite undesirable. Under these circumstances, a regional anesthesia might be better, but it's left for him to decide which technique is preferable in these patients. So patients with HFrEF, patients with reduced ejection fraction, try to avoid general anesthetic as much as you can because of their negative inotropic effect. This might not apply to patients with preserved ejection fraction, and in patients with hypertrophic cardiomyopathy, try to avoid hypovolemia and liberal use of inotropic agents. What about patients who are having electronic devices? This should be interrogated before the procedure. And if there is a pacemaker, usually put the pacemaker in the non-inhibited mode. And patients who are having a defibrillator, usually we deactivate the defibrillator, and then we reprogram them at the end of the operation. Patients with pulmonary hypertension, the ideal thing is just to change the oral drugs into intravenous drugs, but because the intravenous drugs is not available here in this country, then we let them continue on the phosphodiesterase inhibitor or the endothelin antagonists. What about the exercise tests or other cardiac tests for patients undergoing vascular surgery? If you look into this diagram for the exercise test or myocardial perfusion or the butamine stress test, you will find that their sensitivity is around 80–85%. So this means that exercising this kind of patients by this procedure is going to miss one out of 6. So the exercise test should be interpreted carefully under these circumstances. Even if you find ischemia, there is a rumor that patients with ischemia do bad in surgery. Actually, we know from the ischemia trial that ischemia by itself is not correlating with the outcome in these patients. So most of the patients with myocardial ischemia, they undergo non-cardiac surgery with medical treatment and they fare very well. So don't postpone surgery because of the occurrence of ischemia. The most important factor in the exercise test is how long the patient goes on the treadmill. The patient who is going on the treadmill to stage 3 or 4 Bruce protocol, whatever the result in terms of ischemia is, doesn't mean that the non-cardiac surgery will be hazardous or should be cancelled or postponed. So which exercise tests we should implement? If the patient can exercise, of course, he should undergo exercise electrocardiogram. If the patient is having a valve disease, an echo if we are wondering about muscular disease, cardiovascular disease, nuclear.
Here are some pictures that match.
If the patient, if we are concerned about false positive result, then we go to a test of high specificity like the echo. And if we are concerned about left ventricular function, then either of these can be very satisfactory. Now, this is Bayes' theorem after a priest, Thomas Bayes, in the 18th century. He established the theory of probability. Now, let me explain this because this is a very important slide. These are patients who are about 1,100 patients with aortic aneurysm. They have been evaluated according to the number of risk factors into low, moderate, and high. And then, before undergoing surgery, they underwent the dipyridamole thallium test, stress test. And then they were subdivided into low, moderate, or high according to the occurrence or lack of occurrence of ischemia. Now, if you look to the left side of the diagram, patients who have a low pre-test probability when they undergo a stress test and they have a low result, no ischemia, there is a 33%, just a 3% possibility of having major adverse cardiac events. If they get a major ischemia, it is 0%. It is 0%. So this shows you that you can, if you use a patients with low pre-test probability, you get nothing. So we have to be careful that we don't exercise or we don't let patients with low pre-test probability undergo a stress test as an indicator of fitness for non-cardiac surgery. If you go to the right side of the diagram, these are high-risk patients according to the risk markers we indicated. They underwent an exercise test. Whether they have ischemia or moderate ischemia or no ischemia, they are high risk anyhow. So the test is not going to differentiate between who is going to surgery and who is not going to surgery. Probably the important discriminating group is here. Patients with moderate risk factors, if they undergo a stress test and they get no ischemia, they have 1/6 as high the risk of having ischemia. So here the difference is very marked, and this is the most important thing to be considered in the assessment of patients by exercise test or any form of stress test for non-cardiac surgery, is to look what is the pre-test probability. If it's low or high, then the exercise test is not useful at all. Now let me take you into the journey of treatment before cardiac surgery. We'll talk about beta blockers, statins, aspirin, clonidine, and a few comments about hemodynamic monitoring. Now, the story of beta blocker. It all started with the decreases trial in 1994. These were patients with elective aortic surgery. They got many markers, clinical markers of risk, and they demonstrated ischemia on an exercise test. And these people were randomized to take beta blockers or a placebo. Now, what has been shown was just unbelievable. Patients who are taking a Concor or bisoprolol, they have 85% decrease in the risk of getting post-operative myocardial problems. So it's too good to believe. So there is nothing like that in medicine. You get the patient on beta blockers and you get an 85% decrease in the risk. Even the occurrence of myocardial infarction was 100% decreased from 17 to 0. So because this was unaccepted by the majority of people working in the field, the test was repeated, but only 6 years later. And it showed that if you have a score of 0 or 1 risk factors like diabetes or previous ischemia or cerebrovascular insufficiency or other factors, or even if you have a score of 2, there is no value of beta blockers. Only when you get into a score of 3 or score of 4, then the number needed to treat is small, and the beta blocker effect starts to have a value. So because of this confusion, POISE came into play. This is a trial on a large number of patients who have been having diffuse atherosclerosis in the form of coronary artery disease or peripheral vascular disease, and they have been blasted with huge amounts of beta blockers, taking 100 milligrams of metoprolol just a few hours before the operation, and then continuously every day for a month against a placebo. And astonishingly, there was marked decrease in the beta blocker group in non-fatal myocardial infarction, death and cardiac arrest, and in stroke. But fortunately, there was a secondary endpoint in this trial, and that's mortality. And what happened here, the patients with beta block had a higher mortality rate, went from 2.3 in the placebo group into 3.1. So as you see, the story of beta blocker just became a full circle. We now realize that beta blocker is not as effective as we thought at the beginning. And in another group of individuals, beta blockers was only effective if the patients are having heart failure or a recent myocardial infarction within 2 or 3 years. And even in terms of mortality, the only salutable effect of beta blocker was in patients with heart failure. Anyhow, these patients will be on beta blockers without anything. So based on that, the guidelines indicates that patients already on beta blockers for hypertension, coronary artery disease, heart failure, or arrhythmia, they should continue on beta blockers. Patients are on high risks, undergoing high risk surgery, and either 2 or more risk factors or advanced anesthesia association status should be on beta blockers. And if you are going to give beta blockers, you prefer to give beta-1 selective like atenolol and bisoprolol, because these were the two beta blockers that have been used in different trials. And avoid fixed high dose. So you initiate slow and you continue titrating over 1 to 4 weeks, not the day, not the week before the operation. It should be over a long time. So now we are using beta blockers only in high-risk individuals. Think about it. If you have an elderly individual, low body weight, and he's having marginal cardiac reserve, and then he undergoes cardiac surgery, and for example, he gets sepsis or he gets complications like bleeding, he needs to increase the cardiac output. And he increases the cardiac output by increasing the rate and increasing the contractility. And you paralyze these two factors by beta blockers, the patient is going to die in cardiogenic shock. So unless the patient is one of these two, don't use beta blockers. Now, what about the statin? We know that lowering the lipid level is going to improve the result of non-cardiac surgery by about 1/3. This is very well acceptable because this 1/3 decrease in untoward effects is what we get in secondary prevention of statin in general. So all-cause mortality and cardiovascular mortality decreased by almost 30% in these patients. So statins is accepted according to the guidelines for those already on statin for an appropriate indication, or those undergoing vascular surgery, and it's preferable to start again 2 weeks. But you don't need to titrate for a long time. If the patient is having the operation tomorrow, you can start the statin today if you are pressed. Not ideal, but there is no hazard of doing that. There might be some benefit. What about aspirin? This is a large trial called POISE-2, and placebo against aspirin for non-cardiac surgery. Zero effect on mortality, myocardial infarction, DVT, or pulmonary embolism. On the other hand, there was some increase in major bleeding. So there is no value in giving aspirin for patients undergoing non-cardiac surgery, except patients who are having stenting within the previous 5 years. So PCI within the previous 5 years, you can see about 50% decrease in major cardiac events in patients taking statin. So that's the only exception for statin use in these patients. What about clonidine? Now we had the idea that clonidine, and this was implemented by a large number of small trials, blocks the sympathetic nervous system through its alpha agonist effect on the central nervous system. And by doing that, diminishes the sympathetic flow and diminishes the inflammatory response to surgery. But this was not borne out by trials. So these patients, they got more hypotension, they got more bradycardia, and they got more strokes. So as a result of that, you can check this out. No use for clonidine for non-cardiac surgery. So here is the guidelines. Preoperative statin, if the patient is currently taking them for an appropriate indication. Alpha agonists like clonidine, no value. What about revascularization? This is another story which came just full circle like the beta blocker. In the last few years of the last century, we were having the impression that if the patient has been revascularized within the previous 3 or 4 years, then the risk of non-cardiac surgery was less. And as you see here, mortality was decreased, and the occurrence of myocardial infarction significantly decreased in patients undergoing CABG surgery. Now, you might laugh if you know that in these studies, there was no implementation of whether these patients survived CABG or not. You have to survive CABG in order to get the benefit downstream. And that was not taken in consideration. And because of that, a major trial called the CARB was instituted a few years later. And these are patients who having abdominal aortic aneurysm or peripheral vascular disease, left main coronary artery disease, and severe reduction of the ejection fraction below 20 was excluded. And these patients were followed for several months. And the result, zero benefit, both early and late. So with the pendulum swung that the CABG is of no use in preparing patients for non-vascular surgery. And this is very logical because the benefit of CABG and revascularization starts about 2 years after the procedure. So the guidelines, class 3 recommendation, it's not recommended that routine prophylactic coronary revascularization is performed in stable coronary artery disease before non-cardiac surgery. So this goes hand in hand with the results of the COURAGE trial, which emphasizes the importance of medical treatment. So who needs coronary arteriography before non-cardiac surgery? They are exactly the same patients. They need coronary arteriography without the interference of surgery at all. So in the indicators are the same as for patients not being seen for preoperative evaluation, unstable or poorly controlled symptoms on medical treatment, or stable patients with likelihood of advanced multivessel disease or left main, plus minus left ventricular dysfunction, facing high risk surgery. So this is the guideline recommendation for how long you should implement dual antiplatelet therapy. And everyone knows that for the plain balloon angioplasty, 14 days, for the bare metal stent, 1 month, for the drug-eluting stent of the new generation, we have to wait for 6 months. If you are forced to undergo high-risk operation during this period, then it's better to do the operation on dual antiplatelet therapy or at least on aspirin. So don't stop at least one of the 2 antiplatelet therapy. So what are the major risk factors that occur after stenting these patients who are undergoing non-cardiac surgery? The major independent factors are the first 3, non-elective surgery, history of recent myocardial infarction within 6 months, or a risk score of more than 2. There is no effect of whether they are using bare metal or drug-eluting stents. There is no effect of stopping antiplatelet drug, and there is no effect whether the stent has been placed recently or more than 6 months. As you see here, this is a comparison between the effect of stopping the antiplatelet therapy about 6 months, and under these circumstances, you can see that the curve flattens for the drug-eluting stents. It continues to rise with the old generation of drug-eluting stents and with the bare metal stents. But for the new generation of drug-eluting stents, there is a strong evidence that cessation of dual antiplatelet therapy after 6 months doesn't change the effect on the instant thrombosis. Here again, it shows that after 6 months, whether we are talking about drug-eluting stents or metal stents, the occurrence of stent thrombosis, the curve just flattens out after 6 months. So just 6 months of therapy is sufficient for both of them. As a matter of fact, only 1 month is enough for bare metal stents. So the principles of coronary management in patients undergoing non-cardiac surgery is identical to the principles of strategies for patients undergoing coronary surgery in general. And the preoperative moment may be the best chance for the patient to know the appropriate diagnosis which was missed by him. So these are the guidelines. I explained them thoroughly. There's nothing new. If in compelling situations, it's reasonable to allow elective non-cardiac surgery 6 months or more after the receipt of the new drug-eluting stents. What about warfarin bridging? Generally, in cardiology, we try to shy away from bridging. Changing the anticoagulation is exactly the same moment that you are inviting troubles and producing thrombosis or bleeding. All these kinds of operations on the right side of the slide, they can be done on warfarin. So dental cleaning and extraction, bone marrow biopsy, endoscopy with or without biopsy, cataract surgery, pacemaker, implantation, sonography, skin biopsy, skin surgery, joint aspiration can be done on warfarin. Generally, we don't want to bridge 90% of individuals undergoing non-cardiac surgery. You don't need to bridge, you just stop warfarin and don't give heparin. The only 4 indications which apply to about 10% of patients undergoing non-cardiac surgery are these: atrial fibrillation with a recent stroke within 3 months, atrial fibrillation with very high risk score 5 or 6 out of 6, recent venous thromboembolism within 3 months to a year, and the mechanical valves, particularly in the mitral position. So these are the only 4 indications for bridging. You stop warfarin, replaced by heparin, then you start warfarin again, and heparin again, and then you stop heparin again. Bridging in this way only for these conditions, which constitute about 10%. All others, either you continue warfarin or just you stop warfarin and start it again once hemostasis is secure. What about the DUAC? The duration of stopping the DUAC will depend on 3 things: the thromboembolic risk, the bleeding risk, and the kidney function. So if you have a low thrombotic risk and a standard bleeding risk and kidney function is normal, then you just stop it for 2 days. If on the other hand, you have a high thrombotic risk and the bleeding risk is acceptable, then and normal kidney function, you stop for 1 day. So generally we stop somewhere between 1 day to 5 days, depending on the 3 factors that I just mentioned: the thrombotic risk, the bleeding risk, and the kidney function, which connotes whether the creatinine clearance or estimated glomerular filtration rate is above or below 50 milliliter per minute. What about the pulmonary artery catheterization, the Swan-Ganz catheter? in patients undergoing non-cardiac surgery. No benefit. Transesophageal echocardiogram during non-cardiac surgery. No benefit. Routine post-operative screening for troponin, which most of the residents, they start to chase the patient post-operatively with troponin. Unless the patient is having signs and symptoms suggestive of myocardial ischemia or myocardial infarction, there is no benefit in chasing troponin or other biomarkers. So it's very important to realize that patients in the post-operative state, if they get myocardial ischemia or ischemic cardiomyopathy or congestive heart failure, they have a higher incidence of cardiac death and total mortality. So they should be very vigorously treated under these circumstances. And the treatment will be exactly similar to the patients who are not going under non-cardiac surgery. Now, as you see, the bottom line is that the evaluation of patients undergoing non-cardiac surgery relies essentially on clinical examination, taking a great history, making a thorough clinical examination, and looking at the electrocardiogram. Just this. You need a stress test only under very exceptional circumstances, and this is particularly in patients undergoing high surgical risk, risk surgery, and at the same time they have poor functional capacity or unknown functional capacity. Now, if you compare what have been done previously, essentially 10 years ago, and number of stress tests as a result of the new guidelines dropped markedly, number of coronary angios dropped markedly, number of unneeded PTCA or CABG dropped markedly, and as a result of that, the preoperative cost dropped from this figure to almost 1/10. And what about the outcome of adopting the new guidelines? The outcome was almost the same, and even there was a trend towards a decrease in the post-operative mortality, post-operative myocardial infarction, or the combined endpoints of death and myocardial infarction. So I stop at this stage and get questions. I expect a lot of questions because this is a subject that's being practiced every day. محمد.
يا دكتور محمد، انا وحضرتك لسه مفيش اسئله جت.
غريبه. انا متصور ان هو يعني هتبقى اسئله كتير. طبعا I take this chance ان احنا الاسبوع الجاي باذن الله هنأجل المحاضرات. احنا دلوقتي خلصنا يا اما 30 يا اما 31 محاضره. I hope ان كنتوا استفدتوا منهم. I hope ان كنتوا تقروهم. At the same time احنا we can stop for one lecture and نبتدي يوم 5 فبراير باذن الله a series of 5 lectures about the evaluation of the cardiac patient, starting with the exercise test and going through the nuclear, the CT, MRI, and the hemodynamics in cardiovascular disease. So that will be الساعة 7:30 عشان ناخد فرصة نصلي العشاء، لأن العشاء بقت بتتأخر دلوقتي. So 5 فبراير 7:30 كل جمعة لمدة 5 جمعات هيبقى عندكم 35 أو 36 محاضرة covering most if not all subjects in cardiology. Okay. Questions?
اوكي، في اسئله جت. اول سؤال بيسال ischemia discovered by non-invasive testing في the preoperative period. When should we correct it?
If you have ischemia, you treat the ischemia medically, and the indications for intervention is only when the ischemia is resistant to the treatment. Of course, we are talking about symptomatic ischemia. We don't treat asymptomatic ischemia or silent ischemia. But the important point that I wanted to make tonight is that finding an ischemic response on the exercise test doesn't mean that the surgery has to be cancelled or has to be postponed or the decision has to change, because almost 85% of these patients with ischemia, they pass through non-cardiac surgery safely. Only 15% they get troubles by intensive or aggressive medical treatment, and intervention if it is indicated. Same indications like the non-surgical patient. Nothing peculiar. This is important لأن احنا بنلاقي جاي عيان عنده ST depression 1 ملم ولا 2 ملم ولا this patient دي مش الريزلت بتاع الاكسرسايز تيست. لوك مشي قد ايه على التريدميل، ايه الاذر مانيفستيشنز. العيان اللي بيجي له اسكيميا اند هايبوتنشن، او يجي له اسكيميا اند اريثميا، او يجي له اسكيميا اند هي was forced to stop because he got exhausted. ده عيان ما مشيش فتره، ده هاي ريسك. لكن just the occurrence of ischemia is not a significant factor that leads you to change your opinion or your decision or your pathway in treating the patient.
اوكي، سؤال بيسأل على new oral anticoagulants. بيسأل should we assess the bleeding or ischemic risk by Hasbled and Shadravas score or not?
Hasbled is very well known to everybody and it's very valid. You don't need to remember these things. Low body weight, female sex, previous bleeding, anemia, renal disease, cardiac disease, abnormal INR. These are the factors which increase the bleeding. If you don't have these things, the patient has low bleeding risk. طبعا العيان اللي هو عنده recurrent bleeding ده is the highest risk patient. Recurrent hematemesis, recurrent إلى آخره.
اوكي، سؤال بيسأل how to manage abdominal aortic aneurysm size 6.5 cm for low risk procedures like endoscopic procedures.
How to manage the size 6 mm should have surgery. لكن هو إذا كان هيعمل endoscopic procedure because of hemorrhage من esophageal varices مثلا, this is a very low risk operation. Does it need إن أنا أوقف كده وأسيبه يبليد من esophageal varices وأحوله إنه يعمل horrible operation بياخد فيها anticoagulants يزود البليدنج and the patient dies. So if the esophageal endoscopy is urgent, then زي ما انتم شايفين في الالجوريزم an urgent procedure should be done irrespective of what. وبعد كده بعد البروسيدور ده هو اشوف العيان ان هو عاوز يتعمل له ايه، واعمل له 6 سنتيمتر indication of course. لكن النقطه المهمه ان ما يخشش العيان عشان يعمل اندوسكوبي وانا الاقي عنده اورتيك انوريزم ما هواش فيه اشكال، ما هواش سيمتوماتيك، وما اقول له وقف بقى ما تعملش الاندوسكوبي عشان نعمل الابدومينال اورتيك انوريزم. So he dies from anticoagulants اللي ياخدها في الاوبريشن بتاع الاورتيك انوريزم procedure. Now this is not a big problem لان احنا عندنا الايفار بيحل الاشكال دي. This patient will do the esophagoscopy and at the same time on the second day or the third day he can do an EVAR if that's possible أو feasible للعيان.
اوكي، سؤال بيسأل عن value of preoperative troponin in high risk patients undergoing high risk surgery according to the Canadian guidelines.
حتى الكنديان جايد لاينز ما بتقولش انك انت فولو العيانين دول هم بالتروبونين. العيانين اللي عندهم troponin isolated elevation للتروبونين without clinical picture supporting myocardial ischemia or infarction can be due to other things. لو واحد جريله جريتين كده هو هيليكس التروبونين يرتفع. There are several causes cardiac or non-cardiac for elevation of troponin. So don't take troponin على انه هو sign of myocardial ischemia or myocardial infarction. انت عارف ان حتى Canadian guidelines is using the famous word of myocardial injury. So it's a myocardial injury. المyocardial injury ده سببه ايه؟ Could be heart failure, could be pulmonary embolism, could be exercise, could be a variety of things. But if the patient is having pain, ECG changes, that's a different story.
سؤال بيسأل in patients with severe reduction of ejection fraction less than 30 but compensated, should elective operations be avoided or postponed?
Asymptomatic. Compensated يعني asymptomatic. Okay.
Should elective operations be avoided or postponed?
ليه؟ ما فيش حاجة ده. العيان we know ان في dichotomy between the effort tolerance of the patient and the ejection fraction. So a patient with an ejection fraction that is below 30, say 25, but he is able to climb 2 flights of stairs or walk 2 blocks, this is a good functional capacity. So he should undergo an operation اللي انت عاوزها. Only when he has a poor functional capacity or untested functional capacity that we exercise him. If it turns out ان هو عنده low ejection fraction وعنده symptoms on low exercise test يبقى هو كان understating، ما هوش كان هو كان limiting his effort، وعشان كده باين ان هو asymptomatic هو symptomatic heart failure. So under these circumstances you have to think انك انت postpone الاوبريشن unless طبعا لو هي emergency postpone الاوبريشن او change the line of treatment because this is the end of the algorithm.
Okay. How to manage a case presenting with STEMI and the critical limb ischemia at the same time?
يعني STEMI and critical limb ischemia at the same time, this is not a big problem. The STEMI is time domain بتاعه time domain قليل، وبالتالي direction should be in this patient will take intensive anticoagulation and depleted drug, which is very pertinent for both conditions. At the same time, we have to open the coronary arteries, and then we direct our attention to imaging during the same procedure, to imaging the lower limb vessels. And then during the same procedure, then you can get probably by the collaboration between the peripheral vascular specialists and the cardiologist, you get removal of the obstructing clot, obstructing thrombus. So that's a very simple procedure, and we do it every now and then.
Okay. سؤال بيسأل what is the appropriate stage in Bruce protocol at which we can expect that the patient will go safely through the procedure?
Usually we do a complex index which includes duration of exercise, the angina score, and the degree of ST elevation or depression. So this score will tell you whether if the patient is having severe condition like -11 or +5. So this will tell you العيان at the risk. You know, as you go towards a more duration اللي هي الأولانية دي هي، وبالتالي النتيجة هتبقى من ناحية البوزيتيف سايد the mortality rate approaches 5%. So the mortality rate approaches 0.25%. On the other end, mortality rate is 5%. So if you go towards -11, then you started to make to be very careful in dealing with these patients. These patients are usually having left main or three vessel disease. This doesn't mean canceling the operation, لكن it means that you need more investigations. So probably multi-slice CT will be helpful under these circumstances. left main هو the only indication انك انت توقف النون كارديك surgery and then you do the left main first before embarking on the non-cardiac surgery. So we do an exercise test, find out من exercise test اللي هو the range of protection, and based on the range of protection, whether we are dealing with a severe cardiovascular limitation or minor cardiovascular limitation, and depending on that, we choose the appropriate line of treatment.
Okay. How to manage a patient with accidentally discovered AF who is presenting with acute lower limb ischemia requiring peripheral catheterization? And should we start anticoagulation before the peripheral catheterization?
Any threatened limb لازم ندي anticoagulation. And then we try to image the vessel whether non-invasively by CT or MRI or invasively if you are decided in خلاص في a salvaging procedure should be done. So this patient should take anticoagulation in the usual way. Anticoagulation, heparin and warfarin or DUAC under these circumstances. If the only reason for the embolization is atrial fibrillation, I would prefer DUAC. You get anticoagulated within 1 hour. And then depending on what appears in the imaging, يعني أنا هصوره دلوقتي بمالتي سلايس سي تي. There is an occlusion, then it will be followed by invasive angiography with attempts to dislodge الامبولس اللي موجودة through angioplasty or through stenting or through combination. Sometimes in situ thrombosis can be helped by in situ installation of thrombolytic agents and stenting at the same time.
Okay, سؤال بيسأل does perioperative AF require long-term anticoagulation if Shatz-Bask score is more than 1?
If the perioperative atrial fibrillation is de novo, then there is no reason to start it if it's less than 48 hours. If it continues more than 48 hours, then yes, we have to implement anticoagulation. Usually, we try to cardiovert the patient during this period pharmacologically, or if there is hemodynamic instability by electric current cardioversion. And under these circumstances, you don't need to give except 1 shot of heparin. So the cardioversion, 1 shot of heparin. This is the guidelines. What 1 shot is going to do, I don't know. Like in 1 shot of heparin. If it persists or it has been persistent for 48 hours or unknown duration, then the patient should be anticoagulated.
Okay. آخر سؤال بيسأل عن Lee index, how often to use it?
ليه اندكس هو ده الريكري اللي هو الريفايزد اندكس بتاع كارديوفاسكولار كومبليكيشنز. ليه اندكس دي هي ما انا قلت لك ان هو في كانت اسماء كتيره سواء تسكي او ليه اندكس او different names كانت موجوده. كل ده اتلغى وبقينا عندنا الار اي سي اي اندكس اللي احنا بنتكلم عنه. العيانين اللي عندهم هارت فيلير، كرونيك هارت ديزيز، دايابيتس، بريفرال فاسكولار ديزيز، سيربرو فاسكولار اكسيدنت، renal failure or serum creatinine above 2. So all of this is the index which has replaced as per guidelines the others which have been implemented in the previous years. منهم بتاع توماس لي اللي كان موجود.
هو كده خلاص الأسئلة خلصت.
اوكي الجمعة اللي جاية اجازة بإذن الله. الجمعة اللي بعدها هتبقى 5 فبراير ان شاء الله 7:30 نبتدي اكسرسايز تيست.
شكرا
حضرتك على خير يا بيه، شكرا جزيلا.
شكرا يا دكتورة وفاء، شكرا.
صباح على خير. صباح على خير.